Good morning. Thanks everyone so much for joining. This is a topic that's very near and dear to my heart. We'll get into that a little bit more as we move forward with the presentation, but thanks so much for joining us this morning. So this presentation is really applies to a wide variety of people. It applies to healthcare providers in any field, but in particular the behavioral health field, family and friends of anyone struggling with substance use, and those themselves who are struggling with substance use. So our agenda is going to, essentially start with defining what harm reduction looks like. We'll briefly touch on the rates of fatal overdose. I think everyone is pretty familiar with how big of a problem that is, but we'll get into a little bit of the specifics. And then we're going to wrap it up with looking at overdose prevention strategies. So the first, I would like to start with a little story about my brother-in-law. We'll call him Bill, B-I-L, brother-in-law. Bill was, really the life of the party. He's someone who really enjoyed having a good time with friends and family. He had 3 beautiful children, as well as a beautiful wife. And sadly, in 2020, Bill had a fatal encounter with opiates. And he was survived by my sister-in-law and my nieces and nephews, the youngest of which, when he passed away, was just 1 month old. So as we move forward with the presentation, we'll loop back at the end of it and talk a little bit about ways that we could have saved his life. So as far as defining harm reduction as it pertains to substance use, there's not really a generally accepted definition of harm reduction. However, it is known to cover a set of activities that are intended to minimize the negative physical and social impact incurred by the behaviors related to substance use. So that's essentially the World Health Organization look at it. So what we're trying to do is we're trying to take a look at what substance use looks like and recognize that it is a problem. And as community members and as behavioral health professionals, identifying a set of strategies to help minimize the adverse effects of substance use, to make sure that we're keeping people alive. So harm reduction essentially accepts that, like I said, substance use is a problem, right? It's part of our world, and we choose to work as harm reductionists to minimize the harmful effects of substance use rather than ignoring relapse realities. So, the opposite of harm reduction is essentially saying people are going to die and we accept it as a result of substance use. Well, while that is one way of looking at it, what we need to do is really be responsible for taking this head on and saying, okay, if recovering from substance use is difficult, what can we do to keep people alive, even if they're not ready to look at sobriety at this point in time? What are some strategies that we can employ to help keep them alive until we can get them connected to the right, at the right time, so that treatment can be most effective? So realistically, many of you have heard of the stages of change. And this is just a little graphic that explains it a little bit. It's a little bit busy, but I'll go through it with you. So we start at the pre-contemplation stage of change, and then generally move into contemplation, and then to determination, then action. So action is the easiest one to, if you're not familiar with what stages of change look like. Action is when we have people really fully engaged in treatment. So rather than contemplating that they might need to enter treatment, they are actually there in that phase of treatment. So that can look like a bunch of different things. Maybe they are, just full on engaged in their sobriety and they're not using, they haven't used, early on, they're maybe engaged with a therapist, or they've gone to inpatient to detox and then are working a program. And then we move them into the maintenance phase, which is essentially, okay, now I've got a little bit of sobriety under my belt. I'm starting to engage in 12-step groups perhaps, or some type of maintenance treatment. And then one of 2 things can happen. Either they move into permanent exit where they never use again, or they go into relapse. And then they start all over again. So realistically, what we want to do is we want to recognize that, substance use disorders generally have a high rate of relapse, which is not all that uncommon compared to other types of chronic illnesses like hypertension and asthma. There are often relapses. People will have a treatment plan to manage their hypertension, and they will fall off the wagon, so to speak. Type 2 diabetes, coronary heart disease, those types of things. People will be really determined as we see in our stages of change wheel, they'll move into the action phase where, for coronary heart disease and hypertension and type 2 diabetes, they'll, start exercising, they'll be eating well, they'll start to lose weight, they are, drinking less and those types of things, smoking less. And then they'll move on to the maintenance phase. And then oftentimes they'll relapse, or perhaps they have a permanent exit. So substance use in reality, when we're looking at just what relapse looks like, it's not all that different when it comes to other chronic illnesses. However, the overdose deaths in opioids, the relapse realities are generally very fatal when compared to relapses for other chronic illnesses. So in particular, over the last several decades, as you're all aware, we've had the opioid epidemic, and it's been a huge problem. It's led to, as of 2018, nearly 500,000 deaths, right? Realistically, though, it is only getting worse, and it's very tragic. We are seeing just a staggering loss of human life over the course of the last even decade. So when the pandemic hit, after March 19th, 2020, which is about when everybody went on lockdown, 62% of participating counties experienced an increase in overdose. So that's a really significant jump from the prior months. And as we look at that a little bit more, we see that in 2019, we had about 72,000 drug overdose deaths, which was an increase of 29% from the prior year. So these numbers are really, really staggering, and it's only getting worse. So from when we look at 72,000 drug overdose deaths, an increase of 29% in 2020, we've actually seen it jump even higher. Sadly, we hit the milestone of 100,000 deaths over the course of a 12-month rolling period this last year, and there's not any reason to expect that things are going to get better at this point in time, unfortunately. So it's really important that as healthcare providers, as community members, and even those of you who are struggling with substance use who may be listening, it's very important that we start to develop some strategies to keep people alive. That is we've got to stop the bleeding right now. And we do that by employing harm reduction strategies. So before we get into that, I do want to take a look at one other thing here. Opioids in particular are of big concern, right? Fentanyl is a synthetic narcotic, and that is the most worrisome of the substances. However, we are seeing an increase over the last several years of overdoses via cocaine and other psychostimulants like methamphetamines. Additionally, we've got benzodiazepines that are also responsible for a large number of overdoses. So it's not just opiates, and we'll look at what an opiate is for those of you who may be less familiar with it. But I just want to point out that it's not necessarily the opioid epidemic that we're facing anymore. It's the substance use epidemic. So fatal overdoses, especially after a period of sustained abstinence, are far too common. And I want you to remember there's one thing that you take away from the presentation today. It's that sustained abstinence, or even a small period of abstinence, is a huge risk factor for overdose. And that's like I said, the one piece that I want you to take away from this. There are other very important pieces to this presentation, but there's one thing that you take away from it. It's that sustained abstinence is a huge risk factor for overdose. So that's where harm reduction strategies and overdose prevention education become vital safety measures. So the first thing that I want to touch on briefly is Narcan. So Narcan is a nasal spray that counteraffects opioid overdose. So what happens is when someone uses opioids, it sits on receptors in the brain. And these opioids, when they settle into these receptors, are going to have an effect on one's nervous system. So their breathing is going to decrease, their respiratory functions will essentially start to fail if they've used too many opiates. And it's a result of the opioids sitting on these receptors. These receptors in the brain are sending messages down to your nervous system saying, slow down. And so people, that's when they start to stop breathing. That's when they start to get purple, and they get purple fingertips, purple lips, pinpoint pupils, those types of things. So if someone who is experiencing an overdose on opioids is given a spray of nasal Narcan or an intramuscular injection of naloxone, what happens is the Narcan or the naloxone will kick the opioid off the receptor, and settle in there so that the opioid can't settle back into the receptor. So it's going to have the effect of removing the opioids from those receptors, so they're no longer sending the message to your lungs and your respiratory system to slow down. So it's going to kind of jolt that person back into breathing, and it can be very uncomfortable for the person, but it will save their life. So if you can get hands on Narcan, it's something that I carry with me everywhere I go, just because opioid overdoses are happening everywhere across America, including my community and including your community. And for those of you who may be listening from around the world, your community is experiencing it as well. So Narcan is something that you can carry with you. It's safe to administer, even if you encounter someone who, you know, has overdosed on the street. You believe they have overdosed on the street. You hit them with Narcan, and it's not actually opioids that are the problem. Nothing is going to happen to them. Nothing negative. They might get a runny nose if it's an intranasal spray. They might get a little, you know, poke if it's a intramuscular injection. But realistically, no harm will come to them if opioids are not the problem. So it's definitely something that, as a harm reductionist, I encourage people to carry with them where they go. So as I mentioned, relapse is a reality of the recovery process. So while we hope for lifelong abstinence for everyone that's in recovery, the reality is that most people relapse at some point in their journey. And in the event of a relapse, nobody wishes for that to be a fatal experience. So harm reduction strategies help to prevent fatal overdoses, and they do not encourage people to use. So that's the big controversial piece where I really need people to kind of get on board with me and other harm reductionists. When we are telling people that strategies to keep them alive if they should relapse, that's not encouraging them to use again. That's not telling them it's okay to use again. It's kind of like asking someone if they're suicidal, right? There was this old way of thinking that if I ask them, then I'm going to plant that idea in their head. That's not reality. We know that to not be the case any longer, and that's true for substance use and relapse as well. So this is, I think, if you do download the presentation, I think this is the slide that you really want to keep a hold of. Okay, so it looks at under the risk factors, the 5 different risk factors that we'll briefly go over, and then the 5 different countermeasures to counteract those risk factors. So so the first one is using alone. So the risk factor is essentially that when you're using substances alone, in particular opioids, behind locked doors to avoid people noticing, you're essentially restricting yourself from having others help you in the event of a fatal encounter. So if someone is using in their room, they don't want to tell other people in the home that they're using, they lock the door so that they can't be interrupted. That is going to that constitutes a pretty significant risk factor, because if you overdose, you're not going to be able to administer Narcan to yourself. So you need someone to know that you're using so that they can bring you back in the event that you do have a fatal encounter. So this involves getting families on board, which can be a very difficult subject for them. But again, if we can drive home the fact that, although this person may not be ready at this point in time to really engage in treatment, the best thing you can do is keep them alive until they can get to that point, because they will most of the time. So alerting someone that you are using substances is really important if you're the one that are using the opiates, or if you have a loved one that's using them. Letting them know, just tell me, I don't want you to use, but tell me so that I can keep you safe. And then never locking the door to keep people out, because that just delays people jumping in to assist if it's a fatal encounter. And this pertains to alcohol use too. So if you're going to be drinking heavily, we don't want people driving under the influence, right? So nobody's there to take the keys, passing out and falling down and injuring yourself, and increased risk of attempting suicide. So as we know, alcohol use really impairs judgment and impairs impulse control. So when you have someone who is drinking and they are not telling anybody, that can be a definite risk factor for them. All right, so the second risk factor that we'll briefly touch on is combining drug types. So I promised you we would look at what an opioid is. Just real brief overview. Opioids are things like heroin and fentanyl and oxycodone or OxyContin, Vicodin, hydrocodone, and morphine, right? And opioids they do have a place in medicine, right? There's a reason why they are prescribed to people, and that's to block pain sensations. Makes people feel good. It induces drowsiness, however, and it reduces your body temperature. It slows down your heart rate, your blood pressure, and your respiratory functions. So when people use too many, that's when it becomes a problem, right? Respiratory functions fail, heart rate slows down, blood pressure goes down. It becomes a really big problem when you're using too many. On the opposite side of the spectrum, you have stimulants. So those are things like methamphetamine, it's also called meth, crystal meth, those types of things. Adderall, which is prescribed for ADHD and other types of things, same with Ritalin. Cocaine is considered a stimulant as well, and they speed up the central nervous system. So they do the opposite of what opioids do. So they increase your heart rate, your body temperature, and blood pressure, while increasing energy, focus, attention, and alertness. Your depressants are going to be things like, Valium and Xanax, which are benzodiazepines. There's the date rape drug that you may have heard of, as well as barbiturates. Similar to opioids, they're depressants, and they induce drowsiness. They slow down your heart rate and respiratory functions. Now, if that sounds familiar, it's because it is, right? So depressants, I'm going to go back a slide, and opioids have the same effect. So when using those two things, so if you're using a benzo and using an opioid, you're essentially doubling the effects on your body. And in my experience as a healthcare provider, when I'm talking with folks about encounters where they've overdosed, most of the time it's after a period of sustained sobriety and also when they mix a benzo with an opiate. So they'll say, I took a Xanny bar, which is street for a benzo, and mixed it with heroin or fentanyl or whatever, and essentially by combining those two, they've reduced their heart rate and those types of things to the point where it's started to kill them. So alcohol is another type of substance. It has many effects on the body. It contracts brain tissue, destroys brain cells, and it depresses the central nervous system as well. So we've got just 10 minutes left, so I'm going to breeze through a couple other things here, and we're going to get to your questions here shortly. So please, if you have some questions, get those in. But when you're mixing multiple depressants, like I said, you lose consciousness. It can result in a loss of consciousness. It can result in a lack of response to outside stimuli, shallow or no breathing, and those types of things. But mixing opioids and cocaine or other stimulants also is a huge risk factor for overdose, because the cocaine and the amphetamines cause the body to use more oxygen, while the heroin reduces the breathing rate, right? So your body is working really hard while it's essentially being primed not to work hard. So it's a huge risk factor as well. So a countermeasure to review with our clients and our families and our loved ones is that if you are going to use, only use one drug at a time, and this includes alcohol. We also encourage them to use small amounts of substances and to take it slow. That's a big thing that we want to teach people to do if they're going to relapse, is to take it slow, use one at a time, and don't ingest a bunch of substances, on a binge, and be aware of tolerance changes as well. So street drugs are being mixed with adulterants, primarily fentanyl, and that's a big contributing factor to the overdoses that we're seeing. The DEA and other local public health departments have acknowledged that there's a large spike, in part attributed to fentanyl making its way into these substances. So it's really important that we talk to our patients too. So if someone has a cocaine use disorder, or a family or friend has a cocaine use disorder, it's important to let them know, hey, cartels are starting to mix fentanyl in with cocaine, and so someone who's maybe never used an opiate before and may not have any sort of tolerance for opiates may unknowingly have ingested fentanyl, which can immediately result in overdose. So it's a very big risk factor. I'm going to skip over this slide. It's a chart that's just a little bit busy. It talks about the widespread epidemic of substance use that we've got going on across the country. But a countermeasure to street drug adulterants is using fentanyl test strips. So fentanyl test strips, you can you generally acquire them through harm reduction programs. You can find them online and those types of things. And we encourage people who are, if they're going to relapse, to test their supply first. So again, using small amounts, take it slow, test your supply, don't use behind locked doors, and make sure that someone in the home has a Narcan kit. Okay, this slide I really like. I think it's really gives a great visual representation or visualization of how what it looks like when fentanyl is mixed into a tablet, for example. So in this slide, you see the green tablet matrix, and you've got the active substance, which we'll call fentanyl. Essentially, these cartels are blending them together, and the fentanyl is not going to be evenly distributed across the pill. right? So for that middle pill, you've got on the left 1 purple dot, and on the right you've got 3 purple dots. And that just goes to show you that a pill, if you test your supply, you may not pick up on that, but it's still an important thing to do because there's a chance that you do pick up on it, right? So so it is important that we encourage people to understand that pills, as they are, put together, may be unevenly distributed. The fentanyl may be unevenly distributed throughout the tablet. So another important reason why taking it slow is a really good idea. Another risk factor is pre-existing respiratory illnesses like COPD, asthma, pulmonary hypertension, those types of things. Again, if we're ingesting a substance that's going to slow respiratory functions, and we already have a physical health problem with our respiratory functioning, that's only going to increase the risk of overdose and being unable to breathe. So countermeasure is just to be very aware of tolerance changes after periods of abstinence. Do not use alone. Talk to your doctor openly about your historical or active substance use, right? So very, very important. This one, again, big thing I want you to take home today, tolerance changes, okay? Tolerance is your body's ability to process a certain amount of a drug or a substance. So essentially, the more you use, the more your tolerance builds up. So this is true of alcohol, it's true of opiates and other types of substances. So as you start to use more and more opiates, or as one starts to use more and more opiates, your tolerance will rise over time. Now, if you stop, these graphs on the right show, especially the one at the bottom right, it shows your tolerance change over time. So if you're using more and more substances to feel the effects of opiates, and then you stop using for a period of time, your tolerance has gone down. So what happens is a lot of times people will go back to using the amounts that they use if they relapse at the height of their use, and subsequently they experience an overdose. This happens quite often. You see it as folks are getting out of inpatient treatment. You see it as folks are getting out of residential treatment. And you see it as folks are relapsing for the first time after a period of sobriety. So it's really important that we educate people that tolerance change is a big, big risk factor. So how do you counteract that? Use less when you're sick or after a period of sobriety. Even a few days of absence or decreased use can lower tolerance. So just educating them on this alone is a really effective strategy to keeping people alive. So if they are going to use after a period of abstinence, let them know you need to be careful and you need to go slow. Use a small amount initially, and again, go slow. So even if it's just a couple of days. So going back to Bill, just to review the timeline of events. So with what happened with him, because I suspect this is happening with some of your clients as well, if you're a healthcare provider. So Bill tapered off of Suboxone. So he had a period of time where he was on Suboxone, and then he was started on amphetamines for ADHD. So the side effects of the amphetamines resulted in several inpatient days and crisis observation stays because he was either using too much, more than prescribed, or he was prescribed an amount that were causing these kind of secondary effects of what you see when you have too many amphetamines. In May, he broke his arm and he was prescribed opiates for pain management, and he was using more and more to feel the effects of the opiates after that relapse. In June, he went back into an observation unit for 2 days, and then he was transferred to an inpatient setting for 7 days. Excuse me. Pardon me. So he had that period of time in May where he was using opioids again. In June, at the beginning, he went back inpatient for 9 days, and then on June 13th, a few days after he was released, he had a fatal encounter with opiates. So what we suspect happened is that he had a diminished tolerance due to lengthy inpatient stay of 9 days. He had access to the prescribed opioids, which were at home from his arm break, and other substances. And then he used the same amount of opioids he used before going inpatient. So his tolerance change essentially was, his tolerance was greatly diminished as a result of his time away from those substances. So how could we have saved his life as healthcare professionals and as family members and friends? We could have coordinated with the family prior to discharge, right? So I know that requires an ROI. But even if that's not possible, there are other things that we could have done within the healthcare, the behavioral health industry. We could have asked them if we had the ROI to gather remaining narcotics at home to restrict access to those. But there's no reason why we couldn't have provided harm reduction education surrounding diminished tolerance to Bill. We also could have sent him home with a Narcan kit, right? And educated him about using behind closed doors. because when he had overdosed, there were some other people in the home, not his family, but some other folks. So we would have wanted to communicate all of this to all the people in his life. Or we could have stepped him down to a residential level of care. At minimum, a nurse, a social worker, a doctor, a provider, a tech, or a peer support specialist could have provided him with some very basic overdose prevention education, especially around tolerance change. And I believe very strongly that likely alone would have saved his life. And it could have saved the lives of the 100,000 people, some of the 100,000 people who have died over the course of the last year. So it's really, really important that we do this with all of our clients and all of our family and friends. So again, just visiting this this last slide. Take this slide with you, use it with all of your clients, your family, your friends, review it with everybody who will listen. And thank you for listening to the presentation here today. So we'll get to some questions. All right. So looks like the first question we've got is, do you believe that harm reduction strategies, i.e. smart recovery, are effective with alcohol use disorders? Yeah, so yes, I do. And like I had mentioned, I think the piece where harm reduction comes into alcohol use disorder is around relapse starting slow, keeping keys away, so restricting access to lethal means. So if you've got someone who is using alcohol a great deal, they're constantly intoxicated, they're using way too much. There's a lot of research recently that has substantiated that using much less alcohol, not even total sobriety, but just using a lot less, that's a harm reduction strategy in and of itself. So it's a really effective way to tell people, like, look, I hear you that you're having a hard time quitting drinking completely. Sobriety is not necessarily for everyone. Let's at least set a program up where we reduce the effects of alcohol use, or the harmful effects of alcohol use. Cap you at 3 drinks. Okay, that doesn't work. Cap you at 2 drinks. All right, cap you at 1 drink every 3 days or every week. Go to a week of AA meetings and then get a chip, and with each chip, you can hand it in for 1 drink. Those are kind of some harm reduction strategies to help mitigate the harmful effects of alcohol use. What's the fine line between enabling and making using behaviors easy versus responsibility on the individual's part? So it's a really good question, Corey, and this is something that we have a hard time kind of walking that line. So I think when you get hung up on that fence, though, we're missing the boat. And so as opposed to, instead of looking at it that way, I would encourage you to look at, okay, if you're my client, I say to you, I do not want you to relapse. We do not want you to relapse. You should not relapse. This is something that we don't want you to do, okay? If you find yourself in a position where you are alone in front of an opiate, what we want you to do is remember what I'm telling you. Don't use too much. Use a very little amount, because if you do, you will die. And those are the stakes that we're talking about, right? So it's a really big deal, and it's important that we don't necessarily want people to hit rock bottom, because now we know rock bottom for 100,000 people over the course of the last 12 months has been death. Those are the stakes. So we want people to stay sober from drugs and alcohol, and if they relapse, which we know that they're going to do based on the research, we want them to do it in a way that's not going to be lethal. All right, so the other question that we've got here is, how does medication-assisted treatment fit into harm reduction conversation? So that's a really good question. So things like methadone, Suboxone, and Vivitrol are examples of medication-assisted treatment that are a big part of harm reduction. And what that is, some people will say, well, you're just replacing one opioid with another. Okay, well, technically, yes, that may be true, but what we're doing actually is we are prescribing an amount, we are engaging them in a program that's going to mitigate the likelihood that they're going to have a lethal encounter, and hopefully we can step them down from Suboxone over time or methadone over time, or these Vivitrol injections over time, and we're able to get them clean and sober, get some, relapse prevention skills under their belt. So it's just kind of a way of minimizing likelihood of harm. And hopefully over time, we can taper them off. Or maybe they need to stay on for years and years and years. Maybe they need to stay on for most of their lives. There's no problem with that, as long as, they're working a program and they are, engaging fully in their lives and having a fulfilled life. What are common objections you hear from therapists and providers about teaching someone how to relapse? So I think Corey's question, is one of the first ones. Is are we enabling them by having this conversation with them? And I don't believe that we are. I believe that we are just recognizing that this is a reality that most people face during the course of their recovery is relapse. I hear concern about is the legal implications for having a conversation like this. So the way that I've documented my conversations with clients in the past is, I don't want you to relapse. You should not relapse. If you do, I don't want you to die. So here's what I'm telling you to do. So, or telling you not to do, right? Don't use a lot of opioids after a period of sobriety. Don't mix benzos with opioids. Those are big, big risk factors. So that's essentially how I have that conversation with people. Can Narcan be bought over the counter? In some states, yes. So you can get it either through a prescription, or you can get it from, there's a huge harm reduction grant that was recently released from SAMHSA. And it's part of that, I believe, will be that Narcan will be widely made available through community resources. So you can also get them, I believe, from harmreduction.org. That's harmreduction.org. But if you search for how do I get a free Narcan kit on the internet, you're going to find a bunch of different great nonprofits. If you happen to be in Southern Arizona or in Arizona anywhere, Sonora Prevention Works is a fantastic resource for you. They will get you a Narcan kit, oftentimes intermuscular. So it will come with a vial and a syringe. But definitely look for local resources if you can't get one through a pharmacy. All right. Thank you so much, everybody, for joining. Really appreciate you coming in. And if you have any questions, please feel free to reach out to me. My email here is dane.binder@sierratucson.com. And thank you again.